So we are about to start our clinical meeting for the year 2026. So as we all know, the clinical meetings are for exchanging of the ideas, what the juniors, the youngsters are doing in their day-to-day experience, and that will they share with us. And the seniors usually have questions, as because it's a competitive sessions. So some questions are will be there from the judges, and there will be some positive inputs we would like to have if some seniors or some colleagues of us will like to have, but that will be after the end of the discussion. So our principal sir and head of the department sir of the ENT R G Kar Medical College will soon come, but in spite of wasting time, we will go ahead with the program. Just to remind you the rules and regulations of the clinical meeting. So every presenter have a time of 8 minutes for their presentation. There will be a bell and it will ring at the end of 8 minutes. And after 8 minutes of presentation, you will have question answer, and the question answer session will be for the 2 minutes. So 8 minutes for the presentation and 2 minutes for the question and answer, and based upon which you will be given marks, and that will be tabulated, and throughout the year will be the highest scorer will be awarded in our next state conference. So without wasting time, our today's first speaker is Dr. Shubhashree Mondol. Her topic is JNA, tackling a surgical challenge, our early experience. Over to Dr. Shubhashree. So three of the judges are Professor Dr. Amitabh Roy Choudhury sir, Shubhendu Dar, and Dr. Bidhan sir. There will be two bells. One is a warning bell that is at 7:30 minutes, 30 seconds prior to the end, and the final bell.
Respected chairperson, esteemed faculty and my dear colleagues, good afternoon. Today I will be presenting our early experiences in tackling the surgical challenge of juvenile nasopharyngeal angiofibroma, with special emphasis of the evolving role of endoscopic approach. To start with, juvenile nasopharyngeal angiofibroma is a benign but locally aggressive vascular tumor occurring almost exclusively in adolescent male. It usually arises near the superior part of the sphenopalatine foramen and commonly present with recurrent epistaxis, progressive nasal obstruction. Despite being an benign histologically, due to its aggressive nature, it requires detailed imaging and multidisciplinary surgical planning. Previously, this kind of vascular tumor were excised using open approaches. As we can see, exposure created via lateral rhinotomy approach on the left side and exposure created via transpalatal approach in the right side. In case of more extensive disease, even wider approaches were required. Here we can see exposure created via Weber-Ferguson approach. This approach gives wide access, but it is associated with significant morbidity and cosmetic deformity. This open procedure have their drawbacks. The major disadvantages of open approaches are excessive intraoperative bleeding, prolonged hospital stay, and poor visualization of deep extensions. Now, to present our case, 14-year-old male student Bishwanath Karmakar from Damdam Patipukur came to our OPD with chief complaint of recurrent spontaneous epistaxis for last 6 months and progressive unilateral nasal obstruction for last 4 months. I will now briefly summarize the history of present illness. Patient had left-sided nasal bleeding 6 months ago, and the epistaxis was unprovoked and intermittent in nature and sudden on onset, along with gradually progressive left-sided nasal obstruction for 4 months. Now, on examination, anterior rhinoscopy revealed deviated nasal septum to the right side and reddish mass between the middle turbinate and septum on left side. On posterior rhinoscopy, reddish mass seen in the nasopharynx. Next, we did diagnostic nasal endoscopy. In the right nasal cavity, deviated nasal septum present and choana was occupied with reddish mass. In the left nasal cavity, reddish mass seen between middle turbinate and septum, and lateral extension of the mass couldn't be assessed. So, to confirm our diagnosis, we did CCT nose PNS, that is the investigation of choice for juvenile nasopharyngeal angiofibroma. Here we can see a homogeneous mass present in the left-sided nasal cavity, pushing the septum towards the right side, posteriorly extending and completely filling the nasopharynx laterally up to the pterygopalatine fossa and superiorly up to the sphenoid sinus. Now, with better understanding of the endoscopic anatomy and detailed DICOM-based imaging, and also the advancement of the endoscopic technique, there has been a paradigm shift from open to endoscopic approach. We manage this patient using endoscopic modified Denker's approach. Here we are exposing the pyriform aperture. After doing the inferior turbinectomy and medial maxillectomy, there is a bulge in the posterior wall of the maxillary sinus, denoting that the mass completely fill the pterygopalatine fossa. Now we are removing the posterior wall of the maxillary sinus to enter into the pterygopalatine pad of fat. Now we are in the pterygopalatine fossa and searching for our feeding vessel. Here with the black arrow we can clearly see the feeding vessel, that is internal maxillary artery in our case. After ligating the internal maxillary artery, we completely excise the tumor from pterygopalatine fossa. Now posterior septectomy is being done to get a wide access. Here the full final exposure. On the medial side we can see the posterior septectomy already been done. On the lateral side, tumor completely excised from pterygopalatine fossa. This was the specimen that was retrieved after doing endoscopic resection of the JNA. Next, we followed up the patient both endoscopically and radiologically. On DNA, we suspected a recurrence near the pterygoid wedge. To confirm our diagnosis, we did CCT nose PNS. Here we can see on the left-sided nasal cavity there is a mass and near the choana and the pterygoid wedge. So we put the patient on endoscopic revision excision, and here we are drilling the left-sided pterygoid wedge to do the complete removal of the disease. This was the specimen that was retrieved. Here we can see the different parts of the specimen, that is the part from the sphenoid sinus, choanal part, pterygoid wedge with nasal part. Then we followed up the patient and did repeat CCT. Here we can clearly see the drilled out pterygoid wedge on the left side and also complete removal of the disease. So our study spanned 2 years and includes 6 number of cases, with a follow-up period of 1.5 years. We encountered one recurrence which we managed endoscopically, which I already have shown. We are still working on the project and going to publish it soon. Now the advantages of the endoscopic approaches are no external scar, better visualization, reduced intraoperative bleeding, lower morbidity, shorter hospital stay and easier post-operative surveillance. Though our study have certain limitation, that is less number of cases and lack of advanced instruments like coblation and skull-base drill. From our study, the take-home messages are: endoscopic excision has become the mainstay surgical management of juvenile nasopharyngeal angiofibroma. Drilling of the pterygoid wedge has immense role in preventing recurrence of JNA. Even in case of recurrence, the use of endoscopic approach is not only easier but also safe and effective. Here are my references. Thank you.
So before going for any question, I need one thing to be clear. Whether you are presenting a case series or describe a single operative case.
I was describing a single operative
So
case.
it's not a case series.
No,
Okay.
it's a part of a case series which I mentioned later.
Okay. And in this case, you had one recurrence and you went for another surgery. So before that surgery, did you go for any special investigation? You
So-
didn't mention it here. Yeah.
We did diagnostic nasal endoscopy. We
Yes.
suspected recurrence. Then, to confirm our diagnosis, we went for contrast enhanced CT scan of nose and PNS.
Is it sufficient to delineate or identify the site of origin of the tumor or the feeding vessels, whatever we can say?
So, to see the feeding vessel clearly, we can also do some other investigation, but those facilities are not available in our institution, like digital subtraction angiography can be done. And also, if we are suspecting in more extensive lesion, if we are suspecting in any intracranial or intraorbital complication, then we can go for CMRI.
Okay, thank you.
Thank you, doctor. One question is, how long after the primary surgery you detected the lesion?
After 9 months.
9 months. So would you call it a recurrence or a residual?
Sir, after 6 months, we will call this recurrent. And within for the first 6 months, we can call this residual.
Okay. And the second thing, after this experience of this recurrence or residual, whatever, what steps will you incorporate in your next surgery, or you have incorporated, to make sure that there is no residual or recurrence?
Sir, I will go for pterygoid wedge drilling, so that will play a crucial role in preventing recurrence, which happened in this case.
Okay. And what are the contraindication for endoscopic approach?
So, extensive disease which encasing the internal carotid artery and also eroding the skull base. In those cases, we can't go for endoscopy, otherwise there will be residual disease, chances of residual disease, and exposure will be very limited. So, we can't go for endoscopic approach.
Thank you.
Hello. How you manage the feeding vessels in first episode? That is primary operation.
So after the exposure, we will look for the feeding vessel, and we'll first try to take the control of the feeding vessel by ligating, and then we will do the dissection of the mass, either by piecemeal or in block.
Just to interrupt the presentation, as because we are having our respected principal sir and dean sir in the auditorium, so we would like to, and the head of the department of our department is present, so I would like to request all of them to please come on the dais. I will start with my head of the department. Sir, please say something regarding the event.
Respected Principal Sir, Dean Sir, esteemed dignitaries and dear audience, on behalf of AY West Bengal and Department of ENT, Ajigor Medical College, I welcome you all in this clinical session. This clinical meeting, monthly clinical meeting arranged or organized by our AY West Bengal, not only helps our beloved junior residents for their grooming, but also it actually stands for a platform of a knowledge sharing. I hope we will be engaging with few interesting presentations and with fruitful discussion throughout the session. I would like to request my junior colleague Dr. Debabrata Das to carry forward the session. Thank you.
So it's the time to felicitate our principal sir. I would like to request Professor A.M. Shah sir, sir, please come on the dais and felicitate our principal sir. Sir, please come. I again request our principal sir, sir, please say something for the event to encourage us.
Good afternoon, everybody. many distinguished guests are here present. I am very happy also to see many of my seniors, particularly alumni of this college. I particularly congratulate AOI for organizing this type of clinical meeting, monthly clinical meeting in RG Kar. I suppose this also occurred earlier. And this is very much helpful for the PG students because they get the experience for research and also presentation of different research paper, scientific papers in the seminar. So I also hope that this type of seminar will also be organized RG Kar in future also. I express my sincere thanks to the organizer, and I hope a grand success of this event. I will expect all of you enjoy the seminar. Thank you.
Thank you very much, sir. This is the consecutive second year sir is allowing us to conduct this program. Thank you very much again, sir. Shreya ekটু এদিকে চলে আয়, Dr. Shreya Shao, চলে আয় একটু। Now this is the time to felicitate our dean, sir. I'd request Haradhan Bhora sir, please come and felicitate. I would again request our dean, sir, please come and say a few words.
Respected principal sir and faculties, I congratulate the organizing team of ENT department for their sincere effort in arranging this program. I also extend my gratitude to all the speakers and delegates who have joined us today to share their expertise and experiences. Your presence adds immense value to this program. I wish the program grand success and hope all the participants have a productive and memorable academic experience. Thank you.
Thank you so much, sir. Now to go with our program, our next speaker is Dr. Boshundhara Chakraborty. Her topic is Along the Bronchial Trail, Our Experience.
Good afternoon, respected judges and audience. I am Dr. Boshundhara Chakraborty, and today I would like to take you on a journey along the bronchial trail. Bronchial anomalies are quite common in ENT practice, but they may have a diverse clinical presentation and especially high recurrence rates if managed inadequately. Therefore, I would like to share our institutional experience with a few cases. To have a brief recap, the pharyngeal apparatus starts developing at around week 4 of embryogenesis. Initially, there are 6 pharyngeal arches, the 5th one later involutes. The second arch grows caudally, covering the lower arches, forming the cervical sinus. The outer ectoderm-lined grooves form the pharyngeal clefts, while the inner recesses, endoderm-lined, form the pharyngeal pouches. Any defect in involution of any of the structures will give rise to a bronchial anomaly. Coming to first arch anomalies, these are usually present in and around the external auditory canal. Walter Werk did extensive research on this and came up with a classification system. Werk type 1 classification are purely ectodermal lesions, and type 2 contain both mesodermal and ectodermal components. One thing to note here is these lesions may intimately be related with the parotid gland or the facial nerve. The second arch anomalies are the most common. Bailey divided them into 4 types, type 1 being the more superficial ones. The type 2 are anterior to the sternocleidomastoid but are lateral to the carotids. Type 3 are present at the fork of the carotid, and type 4 are present deep in the pharyngeal mucosa. Whenever there is a fistula, these end in the tonsillar bed. The third and fourth arches anomalies, they open in the piriform fossa. The third arch anomalies open at the base, and the fourth arch anomalies open at the apex of the piriform fossa. This is just an overview showing that the first arch anomalies are related intimately with the facial nerve, the second arch anomalies with the carotid bifurcation, and the third and the fourth arch anomalies with the superior laryngeal nerve and the recurrent laryngeal nerve. This is the diagnostic flowchart of the patients. Ultrasound is routinely done. HRCT is done nowadays. MRI with gadolinium contrast can be done when parotid involvement is suspected, and contrast swallow study is reserved for third and fourth branchial anomalies. This is a work type 1 first branchial anomaly, where we see an external opening, and when a lacrimal probe was passed, it is seen going superficial to the parotid gland. So the specimen was dissected and sent for histopathology. This is a very rare case. It is a work type 2 first branchial anomaly, where we can see the tract is deep to the facial nerve. So a superficial parotidectomy had to be done in this case. This is an infected branchial cyst of the second arch anomaly. So this is the CT scan, and after positioning of the patient, this is the routine skin crease incision. Here we can see the great auricular nerve, and after raising the subplatysmal flaps, we now appreciate that the branchial cyst is lying deep to the sternocleidomastoid, and hence the anterior fibers of the sternocleidomastoid had to be divided to reach to the cyst. So some fibers had to be divided, and now we can see the cyst in its entirety with the capsule, which was removed, and the specimen sent for histopathology. This is again a second branchial anomaly with a sinus tract at the lower neck. And here, after an initial incision, we had to go for a step ladder to trace the tract. Here we can see the retracted sternocleidomastoid, the posterior belly of the digastric, and the tract is going deep to the posterior belly of the digastric. We can also appreciate the hypoglossal nerve and the common facial vein, which is formed by the anterior division of the retromandibular vein and the anterior facial vein. The carotid is seen in the distance, and the tract was going deep to the posterior belly of the digastric. So on tracing it, we found that it was ending in the tonsillar bed. So after doing tonsillectomy, when we are pulling the tract, we can see a dent in the tonsillar bed. So the tract was removed in its entirety, and the tonsillar bed was repaired. This is a very interesting case, a case of a middle-aged man presenting with intermittent discharge from the neck for the last 30 years. So when he came to us, there was infected material coming out from the sinus tract, and this is after resolution of the infection. So here, after incision and retraction of the sternocleidomastoid laterally, we can see the tract. The thyroid cartilage is seen, and the tract was seen going deep to the ipsilateral thyroid lobe up to the apex of the piriform fossa. So this is a fourth branchial anomaly. These are again some interesting cases. A brother and a sister, they are siblings, both presenting with bilateral preauricular sinuses and branchial sinuses in the neck. This was operated without any complication. This is a 4-year-old child with bilateral preauricular sinus and bilateral branchial neck sinus. And the child was also hard of hearing. So the hearing test revealed severe sensorineural hearing loss bilaterally. We suspected it might be a case of branchio-otorenal syndrome, but the ultrasound of the KUB region was normal. So main complications associated with these lesions are usually injury to the facial nerve, the 9th, 10th, 11th and 12th nerves, and also the carotid. To conclude, meticulous knowledge of anatomy, appropriate imaging, timely intervention and careful dissection can together form the cornerstone of safe and successful management of branchial anomalies. These are my references. Thank you.
So, what is your take-home message from all these series? Anything special? Any new ideas? Or any new method of surgery? Anything new from this case series?
Sir, we need an extensive anatomical knowledge, and also preoperative investigations are important, especially in second branchial anomalies, which are more common. In those cases, we might need to perform a unilateral tonsillectomy.
Any other instrument you would like to take when you are seeing those lesions or cyst or fistula or tract going between the nerves, through the nerves?
So we can use a nerve conduction monitor to safeguard the nerves and save them, sir.
And when there is a sinus presenting, is there any role of doing any dye test even
Yes, sir.
today?
Methylene blue dye was used, but sir, at times there are multiple arborization of the tract. So nowadays there is a debate on whether to use methylene blue dye or not, sir.
Thank you. Thank you.
Sir.
Our next presenter is Dr. Devaprito Shamanto. His presentation is regarding the bilateral orbital decompression in a thyroid-associated orbitopathy, a multidisciplinary approach.
Good afternoon, esteemed judges, all my seniors and everybody present here. Today my topic of discussion is bilateral orbital decompression in thyroid-associated orbitopathies, a multidisciplinary approach. So thyroid eye disease, as we all know, is an autoimmune inflammatory condition of the orbit associated with Graves' disease, due to which there is enlargement of extraocular muscles and fat expansion, leading to chemosis, increased orbital pressure. The pathophysiology includes, there is environmental and genetic factors like smoking and stress, immune tolerance breach, leading to autoantibody production and TSH receptor activation. Ultimately, they'll come into systemic circulation and there's feedback failure. We see this as soft tissue inflammation and proptosis. Usually, glycosaminoglycans in the eyeball swell up due to its hydrophilic property, and we see them as proptosis. As ENT surgeons, it is crucial that we know orbital apex anatomy, as crowded orbital apex may compress the orbital nerve, and there is a imminent vision loss. Important structures that are around this area are optic canal, superior orbital fissure, and internal carotid artery. We usually encounter exposure keratopathy in thyroid eye disease patients as they present with proptosis, lid retraction, incomplete eyelid closure, inadequate blink reflexes, as a result of which there is corneal drying, epithelial defects, ulceration and perforation. We perform tarsorrhaphy in orbital decompression cases as an adjunct. This is because in severe proptosis, it causes incomplete lid closure, and we tend to see immediate post-op after orbital decompression, there is a increased proptosis due to post-operative edema and inflammation. And we need to protect the eyeball from exposure keratopathy, so we have to perform tarsorrhaphy. Orbital decompression is a surgical enlargement of orbital volume achieved by removal of orbital walls and orbital fat, which will in turn reduce the orbital pressure and proptosis. And it will relieve the optic nerve compression, improve the venous congestion, and protect the cornea. We have to take a multidisciplinary framework, that is, multiple doctors from different disciplines have to come together to treat severe thyroid eye disease. Endocrinologists will have to go for medical management. In case there is failure of medical management, then the patient will be referred to the surgical department. The patient will now come to the oculoplastic surgeons, where there will be adequate ophthalmic care and assessment, and procedures like tarsorrhaphy will be performed. With advent of endoscopic sinus surgery, it has fallen into the basket of ENT surgeons. We are now performing endoscopic endonasal medial wall and floor decompression. Last but not the least, neuroradiologists are helping us for precise anatomical mapping and surgical planning with the help of high-resolution CT and MRI. This is the treatment paradigm for thyroid eye disease. endocrinology guidelines. We have mild, moderate, and severe disease. Usually in mild and moderate disease, we treat with IV or oral medications. However, in the severe cases, we have to go for hospitalization, and in case of refractory cases, we have to go for operation. Pre-op evaluation includes ophthalmic assessment and ENT assessment, like visual acuity, visual fields, exophthalmometry, ocular motility, and ENT assessment includes diagnostic nasal endoscopy. Various types of decompression can be done. For example, medial wall, inferior wall, lateral wall, and superior wall. When we are doing only one wall, we can achieve up to 4 mm reduction in proptosis, whereas if we are doing 4 walls, we will achieve up to 17 mm reduction in proptosis, as we can see from the diagrams. Merits of endoscopic approach over the open approach: excellent visualization of the orbital apex. We can achieve orbital nerve decompression easier. There is no external scarring. Excellent exposure of the inferior and medial wall, and with good amount of decompression can be achieved. Post-op care will include lubrication, debridement, endoscopic follow-up, and thyroid hormone optimization by the endocrine team. Everybody has to work in unison. Complication includes ophthalmic like diplopia, vision loss, and from ENT perspective, epistaxis, sinusitis, etc. This is my patient. There are 3 patients that have come to our institution with severe thyroid eye disease. They were initially treated with IV and oral medications of steroids, and it did not prevent them from having imminent vision loss. So they were referred to surgical departments. Bilateral orbital decompression were done along with tarsorrhaphy for such patients. MRI was done. In each of these cases, there was orbital apex crowding. And post-op, we have seen there was significant improvement in vision in all of the patients. In the MRI, we can see that there is very fat muscle bellies of the extraocular muscles. This is called the Coca-Cola sign. This is the operative procedure of bilateral orbital decompression. We are doing uncinectomy with middle meatal antrostomy. We have to resect the middle turbinate to gain access. There is widening of, and we are drilling the frontal process of maxilla, and we are slowly removing the lamina papyracea. Left orbiter is exposed, and we are incising from posterior to anterior. The fat is bulging out into the nasal cavity. Now right uncinectomy is being performed with right middle meatal antrostomy, anterior ethmoidectomy, posterior ethmoidectomy. Exposure of right sphenoid sinus. Drilling of the right frontal process of maxilla. And now we are slowly scooping out the lamina papyracea to expose the periorbita. We are incising it. And we are seeing the fat bulging into the cavity. So a review of medical literature shows that on the year of 2011, Yang et al. Had highlighted a clear professional practice gap between endocrinologists and oculoplastic surgeons. In the year 2002, Smith et al. Had confirmed that risk modification significantly reduces severe disease progression. In the year 2002, by Bush et al., frontline screening responsibilities of endocrinologists, and clarified that surgical referrals receiving strictly prefer non-contrast CT imaging over contrast-enhanced variants. And in the year 2023, Kamboj et al. Had demonstrated that anti-IGF-1R therapy, that is teprotumumab, achieved statistically significant reductions in proptosis diplopia. To conclude, orbital decompression is effective in severe thyroid eye disease, specifically in dysthyroid optic neuropathy, severe proptosis, and when there is exposure keratopathy. The primary goals are visual preservation, reduction of orbital pressure, and corneal protection. Successful outcomes will require a multidisciplinary approach, and tarsorrhaphy will act as an important adjunct procedure. For optimal functional and cosmetic outcomes, we have to have early intervention, careful surgical planning, and close post-op follow-up. These are my references. Thank you.
So all these are case-based discussion or problem-based discussion. You have not described any single case here.
Sir, my focus was to show that it was important for us to work different disciplines to work in unison to come to a diagnosis and to treat the patient, because we are dealing with an imminent vision loss here.
See, our evidence regarding the level of evidence level of content, one is RCT, that is randomized control trial. Another one is prospective analytical study, case control, descriptive cross-sectional, operative case series, and single case report. These are the 6 level of content
Yes.
that come out as evident phenomena from your presentation. Your presentation belongs to which group? Can you tell us? These are the 6 level actually.
So this has to be a case
yes.
report. It cannot be a case series.
We are coming to this point actually for all the participants. What is this? This is a clinical meeting.
Yes, sir.
Yeah. Here, every discussion should be a clinical case oriented. Not any problem oriented or not any textbook topic oriented. Isn't it?
Yes,
This is not for you, for all the participants. This should be clinical case oriented. Isn't it? Okay.
Our next presenter is Dr. Raghav Gupta. His presentation is Laryngofisher approach and its relevance in contemporary laryngology.
Good afternoon everyone. I am Dr. Raghav Gupta, third year junior resident, and today I am going to present the topic Laryngofisher approach and its relevance in contemporary laryngology, our experience. So what was its history? It was initially done in 1788 by Philip G. Pelletan, performed the first partial removal of laryngeal tumor using a midline thyrotomy. In 1851, Gurdon Buck, first official laryngofisher for intrinsic laryngeal CA. In 1860 by Henry B. Sands and Jacob de Silva. And in 1900 to 1930s, the famous St. Clair Thompson, who we know for the St. Clair Thompson adenine curate, he publicized the surgery for laryngeal framework for early stage vocal cord cancer. This was the article by Sir St. Clair Thompson. What is this? This procedure involves a vertical division of the thyroid cartilage in the midline to allow excellent exposure of endolarynx. Traditionally, laryngofisher have been used for excision of submucosal tumor, anterior commissure lesions, laryngeal web, and selected early glottic carcinomas. Over the last few decades, due to the advent of transoral laryngeal microsurgery, endoscopic instrumentation, coablation technique, use have been significantly reduced. Consequently, it is only used in cases where transaerial exposure is inadequate or complete excision cannot be safely achieved. It remains particularly useful in large submucosal lesions, paraglottic space tumors, and anterior commissure lesions. Several recent reports have demonstrated satisfactory oncological and functional outcomes with this technique. So, the aim of my study was to evaluate the role of Laryngofisher approach in selected laryngeal lesions requiring wide surgical exposure and complete excision. It is also known as median thyrotomy, median laryngotomy, or thyrofisher procedure, the operation of opening the larynx by a median incision through the thyroid cartilage with the formation of a wide window, median laryngotomy or median thyrotomy. So initially, it was used for T1A carcinoma larynx, but now due to the advent of laser and microlaryngeal surgery, it is rarely used for it. For now, recent benign laryngeal tumors are the most useful indication for this technique, can also be used for laryngeal web, congenital acquired, or arytenoidectomy and vocal cord lateralization. Advances in microlaryngeal surgical techniques have restricted the indications of Laryngofisher approach. It is contraindicated in tumor involving thyroid cartilage and anterior commissure and laryngeal papillomatosis. This was a retrospective observational institutional based study done for 5 years in an outpatient department in a tertiary care hospital, the sample size being 6 patients after proper clearance from the institutional ethical committee. Inclusion criteria was patient with laryngeal lesion who underwent surgical excision by Laryngofisher approach, and the exclusion criteria being patient managed endoscopically or transoral approaches, patient lost to follow-up, or patient with malignant laryngeal lesions because they underwent total or partial laryngectomy. All patients who presented with hoarseness of voice, they underwent clinical evaluation, detailed history, fiber optic laryngoscopy, radiological imaging, and then routine pre-op investigation. The decision to perform laryngofissure was taken in cases where adequate endoscopic exposure was difficult or complete excision through a transoral approach was considered inadequate. The laryngofissure approach was then performed under general anesthesia through midline thyrotomy approach. Excised specimen was sent for HP, and all patients were followed up clinically and endoscopically for the assessment of recurrence or airway status. My first patient, 60 years, presented with difficulty in breathing since 6 months and hoarseness of voice since 4 months. Fiber optic laryngoscopy showed endotracheal growth, occluding almost whole of the larynx with narrow glottic chink. This is the fiber optic laryngoscopy of the patient and the CT scan of the patient showing a smooth proliferative mass, occluding almost all of the glottic chink. The patient then underwent tracheostomy and direct laryngoscopy guided biopsy, but the reports were inconclusive, so we decided to go for excision and removal of mass via laryngofissure approach. These are the anatomical landmarks: the hyoid, the cricoid, and the thyroid. The incision, a full-length horizontal incision was given along the thyroid cartilage. Subcutaneous plane was then done, and it was then retracted by a mastoid retractor. Incision was given over the pericordium, a vertical incision over the thyroid cartilage, and both the incision was then left by a single hook retractor. Then dissection was done in the endolarynx by an iris scissor. The mass was then delivered. The undersurface of the mass was then scooped via a Fier's elevator. The smooth proliferative mass was taken out. Now, to prevent the stenosis, we had to give a silastic block in the larynx. So, the silastic block was placed in the larynx. A straight needle was then taken, and on one side, the straight needle was passed through the skin and subcutaneous tissue, then via the silastic block, then the subcutaneous tissue and skin over the opposite side. Wound was closed in layer, and then to keep that silastic block in position, we had to use buttons so that it remains in position. After 3 weeks, the silastic block was removed under direct laryngoscopic guidance, and then this is the post-operative FL after 3 months of the patient who had regained normal voice. Another patient came with hoarseness of voice since 6 months, a solitary large pinkish papillomatous lesion at the junction of anterior ventral and posterior two-third of the left true vocal cord. This was the fiber optic laryngoscopy of the patient. The patient underwent tracheostomy and direct laryngoscopy guided biopsy was done, and the HP reports came out to be mitotically active leiomyoma. We decided to go for excision and removal of mass via laryngofissure approach to see the nature and the extent of the mass. We underwent through the same steps as shown before, and this was the mass which was taken out. This was the post-operative FL of the patient after 3 months. These are the case series of my 6 patients who underwent laryngofissure approach. So the age of the patients ranged from 24 to 60 years with a mean age of 39.6 years. 4 were males and 2 were females, the ratio being 2:1. Rare mesenchymal tumors constituted the majority of the case in my presentation, including 1 schwannoma of larynx, 1 giant cell tumor, 1 angiomyxoma, and 1 laryngealioma. 2 patients who had huge vocal cord polyps were also removed. The laryngofissure approach thus provides adequate exposure and facilitated complete excision in all cases. Post-operative airway and voice outcomes were satisfactory in majority of the cases. Complications are webbing of the anterior commissure, laryngocutaneous fistula, non-healing thyrotomy, and poor quality voice. So laryngofissure, also known as median thyrotomy, provides direct exposure of the glottic and the supraglottic components. Although the advent of transoral microlaryngeal surgery and transoral laser surgery has significantly reduced its use, it can still be used for large submucosal lesions with poor endoscopic accessibility. In this series, all were uncommon laryngeal pathologies including schwannoma, giant cell tumors, angiomyxoma, and leiomyoma. These rare tumors often pose diagnostic and surgical challenges. Laryngofissure provide excellent surgical exposure, facilitate bimanual dissection, and allows complete tumor excision. This approach was particularly valuable where endoscopic visualization was inadequate. Despite disadvantages such as external scar, possible need for tracheostomy, and longer postoperative recovery, laryngofissure still remains an important surgical option in a carefully selected laryngeal lesion. The limitations of my study was sample size was small, study period was relatively less, and study was done in a single center. So, to conclude, advances in microlaryngeal surgical techniques have restricted the indications of laryngofissure approach, but it may still be used for large benign laryngeal lesions which are difficult to be removed by transoral use. Options of choice where laser is not available and complications are rare. These were my references. Thank you.
Thank you, doctor. The question is, it's a very good prospective study that you have presented.
Thank you, sir.
Now, laryngofissure operation is not everyday operation.
Yes, sir.
And you have still, it's like a revisiting the
Yes,
technique.
sir. Yes, sir.
Now, for example, that patient you showed,
Yes, sir.
could you have done that without disturbing the, how about the endoscopic procedure? Just go back to the picture you showed just now. So, what could you have done with a endoscopic approach or
So, sir, we
microlaryngoscopy?
tried by endoscopically the amount, we tried taking out the biopsy, how much soever we can take, and then we sent for HP, and this was came out to be leiomyoma, sir. So we had to excise it fully. So that is why we went for a laryngofissure approach, sir. Sir, if lasers were available in my facility, we could have gone for a laser exchange of the
Yeah,
approach.
that's what I'm coming to. That
Yeah,
in,
sir.
in case you had laser,
Yeah, we
you
might
could
go for a
still
laser
have
approach,
done
sir.
it without disturbing the thing.
Yeah, yes, sir.
Second question is, how would you prevent webbing of the vocal cords after this surgery?
So we went for a stylistic sheet. We put it inside the larynx.
But you said you put a block.
Yes, sir, yeah, stylistic.
Block
sir.
will help restoring the laryngeal
and-
framework.
Yes, sir. Yes, sir.
But block will not prevent webbing, I think.
Yes, 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 sir.
Then, as you said, stylistic sheet
Yes, yes,
should
yes.
be
Yes, sir.
presented.
Yes, sir.
Thank you.
Hello. You mentioned the lock, but here the question of stylistic seat. Have you got any experience about stylistic seat?
No, sir.
How you close the larynx actually? After completion of the surgery, you have put this block, then how do you close the larynx? Apposition of the cartilages, apposition of the pericardium, soft tissues, just tell us.
Sir, it is closed by, sir, this suture only use, sir, vicryl suture, sir.
How do you oppose the, to allow of the thyroids,
To allow of the thyroid, sir.
thyroid cartilage?
Yeah, we sutured the
With
thyroid
what
outlet.
suture?
The suture, sir, we used was this vicryl suture, sir.
Permanent or absolute?
Thank you, sir.
Thank you.
Our next presenter is Dr. Nilanjan Chando. His presentation is regarding frontoethmoid mucocele.
Good afternoon, respected judges and teachers. I am Dr. Nilanjan Chando, PGT MSc ENT. Today I will be presenting frontoethmoidal mucocele, our experience. What is a mucocele or paranasal sinuses? It is a epithelium-lined mucus-filled sac within one of the paranasal sinuses that causes expansion of the sinus cavity with erosion of the erosion and displacement of the adjacent structures. The most common site of the mucocele formation of the paranasal sinuses is frontal sinus due to its narrow drainage pathway, and the second most common site is ethmoid sinus. When both the sinus, ethmoid and frontal sinus is involved, that is called frontoethmoid mucocele. Then maxillary and sphenoid mucoceles accordingly. Any obstruction to the mucosal drainage pathway of the paranasal sinuses may lead to mucocele formation, like chronic rhinosinusitis, obstruction to the frontal recess, previous phase causing mucosal injury, synechiae formation, and trauma, nasal polyposis, etc. Most commonly, the patients present with frontal headache, unilateral proptosis, diplopia, epiphora, sometimes nasal regurgitation and nasal obstruction, and localized facial heaviness. In late stages, meningitis and intracranial abscess. Now, it is a case of frontal mucocele. He is a 77-year-old male with mucopurulent discharge from the superior part of the upper eyelid. The pre-op DNA shows polypoidal unsnate process and pass in right middle meatus. The CECT orbit shows the anterior table erosion and expansion of the right frontal sinus. The MRI of PNS shows frontoethmoid mucocele and abscess formation in bilateral maxillary sinusitis. It is the operative procedure, that is draft 2B. The pus is coming out from the frontal recess. The swab is taken for the culture sensitivity and other tests. Now the mucoperiosteal layer is, it is the frontal floor drilling started and the wide frontal sinus cavity seen with the intact posterior table. This is the fistula. This is the into the frontal sinus cavity. This is the post-op video showing the wide right frontal sinus cavity. The management was a right draft 2B with left face and fistula closure under general anesthesia. This is a case of right ethmoid mucocele. A 30 years old male patient with right exophthalmos. CCT orbit shows hypotenuse lesion at right nasolacrimal and ethmoid sinus region. MRI of PNS orbit shows ethmoid mucocele likely bulged into right orbit with bilateral maxillary sinusitis. DNE shows polypoidal right middle meatus with medialization of the right middle turbinate and the unsent process. Definitive management was septoplasty for access with right face and decompression of ethmoid mucocele with orbital decompression. Now, she is a 13 years old old female with swelling at left lateral aspect of the nose near medial canthus. MRI shows hyperintensity in the T2 weighted MRI and the hypointensity in the T1 gradient MRI and isointensity in the CT scan. DNE shows bulging and at the anterior aspect of the left of the middle anterior aspect of the left middle turbinate and medialization of the unsent process. Definitive management was septoplasty for access with left face. In the postoperative period, we can see a synechiae formation between lateral wall and the middle turbinate. A 7 years old male child presented with painless, gradually progressive swelling at the left lateral aspect of the nose. NCCT PNS shows heterogeneous lesion with mucosal thickening at right side of the ethmoid air cell, associated with gross thinning and dehiscence of the adjacent lamina papyracea. The MRI shows ethmoidal non-enhancing SOL with mass spec over left anterior aspect of the orbit, likely benign query mucocele. And definitive management was endoscopic decompression of the mucocele under general anesthesia. This is the mucocele. And wide frontal recess and frontal sinus cavity. So, mucoceles may be primary lesion or secondary to other underlying conditions that are easily missed on initial evaluation. Most commonly involved, frontal sinus is most commonly involved, 60 to 89% of all paranasal sinus mucocele cases. Ethmoid sinus involved in 8 to 30% of all cases. Mostly adult population is involved, and both male and females also involved. Frontoethmoid mucocele due to long silent period allows significant enlargement. By the time the symptom emerge, bone erosion and structural displacement may already be well underway. There is some complication of the surgery like CSF leak, meningitis or brain abscess, pneumocephalus, local surgical site infection, synechiae formation, etc. In the postoperative period, we manage the patient with nasal irrigation, corticosteroid for the coexisting sinusitis, frequent debridement, and follow-up in regular interval, imaging in susceptible recurrence, repeated postoperative diagnostic nasal endoscopy. So, mucocele of the PNS is epithelium-lined mucus-filled sac Any obstruction of the mucosal drainage pathway may lead to mucosal formation. It can present with varying ranges of symptoms according to the progress and position. Accurate mapping heavily rely on high resolution CT scan and MRI. CT scan to inspect for any bone erosion, MRI to differentiate between the content. Thorough marsupialization, adequate and wide drainage is mandatory to prevent recurrence. Thank you.
Thank you. Is there any role of stents in this patient?
Yes, sir. Some studies show in some stenting in the frontal recess to patent to remain to keep patent the pathway. That is called frontal trepanation.
You have drilled the floor of the frontal sinus.
Yes.
What is the limit of drilling?
Sir, here is we perform draft 2B.
Yes.
So, sir, the limit is from the lamina papyracea to nasal septum. In case of draft 2B. Sir, draft 3 is the removal of the bilateral frontal floor along with interfrontal septum to create a common cavity from one side of middle turbinate to other side's middle turbinate.
Okay. So you had synechia in one case, no?
Yes, sir.
Between the middle turbinate and the lateral wall.
Yes.
What could be done to prevent this synechia?
Sir, vulgarization of the middle turbinate.
Anything else?
Sir,
some flaps, anteriorly west, inferiorly west flaps, that can be reposed after drilling on the raw bony areas. These are there, no? Okay.
Our next presenter is Dr. Ambi Katyani. It's an interesting one, that is unusual nasal presentation on chronic use of analgesic spray, a hard lesson learned.
Good afternoon, esteemed judges and everyone present here. I am Dr. Ambi Katyani, a DNB ENT PG trainee, first year. Today I am going to talk about unusual nasal presentation on chronic use of an analgesic spray, which taught us a hard lesson. My patient, a 46-year-old female, resident of Kolkata and a homemaker, Mrs. Pompadash, presented to us with a nasal deformity for last 1 year and nasal regurgitation of food and liquid for last 6 months. There was also a history of massive epistaxis 2 months back. The summary of the history of the presenting illness is that the patient noticed the deformity of nose about a year ago, which progressed to palatal deformity and nasal regurgitation of food and liquid in 6 months whenever she tried to swallow. It was also associated with hypernasality of speech and pain in left eye, along with multiple episodes of epistaxis, in which the last episode was 2 months back, which was managed at a local clinic, after which 2 units of PRBC was transfused. There is no history of previous nasal surgery or recent trauma. The patient had a significant past history in which she had undergone bilateral knee plating in the November of 2023, after which she was prescribed an analgesic nasal spray, which was composing of tapentadol hydrochloride, given as SOS management for pain. But the use increased up to 10 to 12 times per day extensively for last 2 years. She discontinued the use of the nasal spray 5 months ago. There are no other known comorbidities. On examination, saddle nose deformity was evident. There was left eye ptosis with tenderness, but there were no visual loss. On diagnostic nasal endoscopy, gross secondary atrophic changes with complete erosion of nasal septum, soft palate, most of hard palate, and lateral nasal wall was seen. Only lateral wall of both maxillary sinus were visible. Superiorly, entire skull base was eroded, creating one big cavity. As we all can appreciate, there is the saddle nose deformity and intraoral communication with the nasal cavity can be seen. There were some lab investigations done in which the anti-nuclear antibody profile was negative. The tissue biopsy was positive for non-albicans candida, but negative for other infective causes such as tuberculosis, leprosy, and fungal infection. It was also negative for neoplastic causes like basal cell carcinoma. All investigations for autoimmune pathology and immunodeficiency were negative. The radiological investigation first done was CT scan of nose and paranasal sinuses, which showed blocked frontal sinus drainage pathway and sphenoethmoidal recess, complete erosion of septum and lateral nasal wall, along with bilateral uncinate process. MRI phase showed erosion of some parts of hard palate and complete soft palate. So after meticulous investigation and history taking, a provisional diagnosis of tapentitol-induced osteocartilaginous destruction was achieved along with secondary atrophic rhinitis. The management plan drawn up for this patient was weekly endoscopic debridement of necrotic tissue under general anesthesia until healthy tissue was seen, and palatal reconstruction was considered by team of plastic surgeons using local flaps to support the palate. However, after first session of debridement, the patient was lost to follow-up. So during the first session of debridement, these are the intraoperative findings in which there is complete loss of intranasal anatomy and extensive palatine erosion. So now introducing the tapentitol hydrochloride. It is a dual mechanism working analgesic agent. It is a mu opioid agonist and also a norepinephrine reuptake inhibitor. It comes with lower risks of respiratory depression as compared to other opioids. Its analgesic action is not dependent on an active metabolite, unlike tramadol. So in the literature, like Butler et al., there is evidence of lower risk of abuse and dependence with tapentitol. However, reports from India such as Basu et al. 2018 and 2020, Kathisaran et al. 2019 and Mukherjee et al. 2020 documented cases of tapentitol abuse and dependency, primarily through oral administration with some intravenous use. Patath, Narayan, Suresh Kumar et al. Of 2025, a recent paper of tapentitol use disorder with nasal spray formulation leading to rapid nasal cartilage destruction in a young male was documented. There are certain learning points. Emerging evidence of misuse of tapentitol can be seen as the variety of cases are being reported. Recognizing such rare but devastating complication is urgently required. Enforcing stricter regulatory control and heightened clinical awareness is need of the hour. These are my references. Thank you.
In your endoscopic examination, did you get any mucosal ulcerations?
Sir, the mucosa was absolutely not normal. Like, it was not a normal mucosa.
There was atrophy of the bone and cartilages.
Yes.
But you didn't mention anything about the mucosa pattern actually.
Okay.
The mucus secreting glands, how they were there, how it was look like actually. What was your DNA finding about the mucosa?
So the mucosa was completely eroded. Like
Bones were bare, cartilages were bare.
Bones and cartilages were also eroded.
Opened.
Yeah.
Thank you. Very nice presentation. Very nice case. One question. Hypothetically, if the patient turned out to you in a unconscious state or whatever, unable to give any history, what would be your differential diagnosis?
Sir, first thing I would have gone with some infective causes, as tuberculosis is very common. Apart from that, autoimmune diseases like sarcoidosis, granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, even immunocompromised states like HIV could have led to this type of presentation. Rhinoscleroma could have led to this type of presentation. So keeping all that in mind, we tried to take the history, but nothing was positive. After which we could conclude that this is a tapentadol-induced osteocartilaginous destruction.
Thank you. I hope you get more surprises in future for us. Thank you.
Thank you.
Really an interesting one, we learned also. So the next presentation is also again an interesting one. He has given an title, it's on Making Invisible Visible, a team approach with innovation in difficult MLS scenarios. The speaker is Dr. Atul Anand.
Good afternoon, everybody. Myself, Dr. Atul Anand, an ENT PGT. I am going to talk about making invisible visible, a team approach with innovation in difficult MLS scenario. Structural barriers often obscure critical vocal cord pathology. Traditional laryngoscopy creates a visual graveyard, hindering access and risking recurrence. I am going to talk about 3 such cases that I have encountered during my training period. My first case is a 39-year-old male patient who presented with hoarseness of voice in 6 months, insidious in onset and gradual progression. He was not having any substance abuse history or any comorbidities. We found that he is having a right vocal cord polyp in anterior 1/3 part. He underwent MLS plus biopsy under GA. During the surgery, we found that it was difficult to visualize the anteriorly situated polyp. Therefore, we had to use multiple things to visualize it. First thing we did was we gave a tie anteriorly to give a posterior compression, cricoid compression to make it visualize, but still it was not visible. Therefore, we had to use a burp maneuver where pressure was given externally with the help of fingers to visualize it. Still it was not being properly visualized. Therefore, we had to use a neuro wet patty to keep it inferior to it and push it a little bit upwards. Then with the help of a curved instrument, we pushed it into the visual field, and then we went for the resection. My second case is a 64-year-old male patient who also presented with hoarseness of voice since 3 months. There were no history of training of voice, fever, chills, cough, etc. He was also a non-case of hypertension and diabetes. Right vocal cord cystic swelling was noted over anterior 1/3 portion, extending up to the level of anterior commissure. Here, despite using all the earlier mentioned methodologies, still it was not properly being able to be resected. Therefore, we had to get the help of endoscope. Here we are using endoscope used for urological procedures, 30 degree, which is having a long shaft, and here forehand technique has to be used for a successful resection. My next case is an 88-year-old male patient who presented with dyspnea and throat discomfort since 5 months. We found that there was a well circumscribed pedunculated mass on the left vocal cord on the anterior 1/3 part. Later biopsy revealed a squamous cell carcinoma. But during the time of surgery, when we tried to resect at the level of the pedicle, despite using the earlier methodologies, there were some difficulties. We had to use a wet neuropathy. We inserted it below the pedicle level to push the pedicle a little bit superiorly, and with the help of the harmonic scalpel, we resected it out. So, hidden areas of MLS basically includes the anterior commissure area and the surrounding area. There are various parameters that decides this invisibility. One of the most important problem is the limited cervical extension. Restricted neck movements perhaps prevents the necessary alignment of the oral, pharyngeal and the laryngeal axis. Narrow mandibular space also creates a problem because tight space constricts the laryngoscope path, limiting the lateral and anterior sweep of the instruments. Prominent maxillary incisors, they act as a fulcrum, causing significant risk of dental trauma during forced visualization. Here we can use dental guards. How to visualize the invisible thing? We can either use a hybrid approach where we are using microscope as well as endoscope. Angled telescopes can be used. Then HD visualization technologies are available nowadays. Curved instruments can be used. most important, anesthesia also plays an important role in helping in visualizing these pathologies. Basically, we have to use a small diameter endotracheal tube, or we can either use a jet ventilation to maximize the laryngeal lumen and get a space for surgical maneuverability. Assistant's role is important. To provide a celiac maneuver or to provide a burp, we have to get the help of the assistant. Surgical technologies like endoscope are also important. Patient positioning, then we have to get position the patient in such a way, example, sniffing position. Then laryngoscope selection has to be proper. We have to use an anterior commissure laryngoscope. External compression has to be provided. Then endoscope can be integrated whenever there is necessity. And there should be a dynamic feedback. We have to continuously talk with the anesthesiologist during the ongoing surgical procedure. Wherever there is muscle relaxation required, we have to get it from them. Now, first shows the endoscope, urology, which we use in urology. It's having a long shaft. Then customized curved instruments are also available. Then in this, that is a MLS tube used for laser surgeries. It is a metallic tube, but the problem with this is that it's having a 6 millimeter diameter. This can cause hamper the vision of the anteriormost level. During that time, we can use this MLS tube. MLS tube ranges from 4 to 6 millimeters in diameter. Then here we can use the MLS tube. We can cover it with a wet gauze, or we can use a wet neuropathy to prevent injuries. And this usage of this small tube helps in more visualizable field. In order to, this is methylene blue getting injected into the cuff area. Any breach during the laser surgeries can be immediately detected. Then this is the cricoid pressure or celiac maneuver that is used for visualization. In this, we can see the burp maneuver, backward, upward, rightward pressure being given. This is a new laryngoscope apparatus system where there is an extra pedicle where there is a lymph directly descending upon the cricoid, and with the help of the screws, we can control the anterior pressure given. This is the newest modality, exolaryngoscopy, where there is a system works similar to laryngoscope itself, but there is instead of this directly inserting the endoscope, we have an endoscope outside the surgical field, where the surgeon can use both the hands. These are certain reference articles I referenced. My take-home message is that, in conclusion, it is essential to acknowledge the complexities presented by hidden areas of the larynx, particularly the anterior commissure and subglottis during MLS surgery. Despite these challenges, advancements in technology and innovative techniques make it possible to navigate these regions successfully. By utilizing modern equipment and adaptive strategies, we can enhance surgical outcomes and minimize complications. Embracing these developments not only ensures a smoother surgical experience, but also reinforces the commitment to provide the highest standard of care for our patients. These are my references. Thank you.
Thank you, Dr. Atul. You have shared your journey about difficulties and how you managed it, but can you tell us how you evaluate a larynx to predict a difficult laryngoscopy in the clinic before you take up
the most important thing that we use is a direct laryngoscopic visualization in OPD itself. If it is a very anteriorly placed pathology, like for example a polyp at the level of the anterior commissure or at the level of anterior 1/3, then we already anticipate that during the surgery there can have a problem of visualization. We will first start with giving an external bandage and providing a celiac maneuver, but simple celiac maneuver or burp maneuver.
Next. No, I am saying, yeah, that is one. What other things you evaluate in the clinic to predict a difficult laryngoscopy?
To predict the difficult
exposure.
Difficult exposure. Okay, sir. One is, sir, ASA. The ASA criteria that is actually used for the laryngoscopic for intubation, that criteria also indirectly tells us regarding the
what is it called? It's Mallampati.
Mallampati, yes, sir. Mallampati scoring, yes.
What other measurements? Yeah, now that you have faced difficulty, I think you should go ahead with a structured way to evaluate.
Yes, sir.
There are multiple features, anthropometric measures, as my colleague is telling me, thyromental distance. There are multiple other things.
Yes, sir.
So that has to be
Incorporated into
measured,
yes, sir.
so that you can plan, as you said. Thank you. Anything else?
In your series, what is the percentage of difficult larynx? I mean, difficult introduction.
Percentage of difficult.
Percentage.
Sir, out of like 10 to 12 patients, if we are seeing in an OPD, especially laryngeal cases,
Yeah.
2 or 3 patients will have an anterior commissure attached.
Okay, okay.
No question, actually, just one suggestion or request.
Sir.
There was one slide exposing the identification of the surgeon. As it is a competitive session, it should not be there. Okay?
Sir, really, sir.
Okay, thank you.
Thank you, sir. Thank you.
The next topic, presenter is Dr. Akshay Jain, difficult situation in STEPI surgery.
Good afternoon, everyone. I am Dr. Akshay Jain, and today my topic is stepidotomy, a surgical finesse, and difficult situations in STEPI surgery. So I am presenting a case series of 3 patients in which we have encountered overhanging facial nerve. So I'll start with my case 1. A 30-year-old male presented with bilateral progressive hearing loss from the past 15 years. It was insidious in onset and gradually progressive. There was no history of tinnitus, vertigo, ear discharge, ear pain or facial weakness. No known comorbidities or prior surgeries. On examination, bilateral EAC was normal and TM was intact. Tuning fork test, Renes was bilateral negative, Weber was centralized and ABC was slightly reduced. On PTA, what we found, right moderately severe mixed hearing loss and left moderately severe mixed hearing loss of 63.3 decibel. We have done HRCT. On HRCT, sclerotic mastoid and hypoplastic air cells was present. So in the right ear, we have done right reverse stepidotomy plus piston insertion. In this patient, intraoperatively, we have found overhanging facial nerve and foot plate was fixed and incudostapedial joint was intact. In left ear surgery, left reverse stepidotomy plus Teflon piston insertion was done. Foot plate was fixed with reduced mobility. Overhanging facial nerve was there in this side also, and incudostapedial joint was intact. This is the surgery. What we have given the incision. Now we are going to elevate the tympanomeatal flap. Itecotomy was done for the better exposure. As you can see, here's the facial nerve. This is the immediate post-op. Sound is not coming. Patient can hear even the whisper sounds. Case number 2. A 30-year-old male presents with the bilateral progressive hearing loss for the past 6 years. Patient was a known case of otosclerosis. Patient was diagnosed in 2013, and in 2013 only right stepidotomy plus stapes piston insertion done. Till 2020, patient had no symptoms. Then from 2020, patient started having hearing loss again. PTA was done, and the right mixed hearing loss and left conductive hearing loss was found. Tuning fork test, Renes bilateral negative, Weber centralized and ABC slightly reduced. In this patient, we have done revision partial stapedectomy, malleolo-vestibulopexy with Teflon piston insertion, and temporalis fascia graft based stapes footplate reinforcement was done.
हम जो बोलेंगे आप आंसर करना.
In this patient, as you can see, long process of incus was eroded. This was the previous piston that we had removed. We have placed the piston over the handle of malleus. We are placing the graft. The guarded prognosis was explained to the patient about the hearing.
हम जो
This was
बोलेंगे
the
आप
immediate
आंसर
post-op
करना
result.
ठीक से।
ठीक सर।
आपका नाम क्या है?
संदीप महतो।
Patient was able to hear. Case 3, 38-year-old male presented with bilateral progressive hearing loss from the past 7 years. Incidence in onset gradually progressive. No history of tinnitus, vertigo, no known comorbidities, and the examination was normal. We have done tuning fork test and PTA. In this patient, we have done right reverse stepedotomy piston insertion. On follow-up, what we have found is patient developed right facial paresis on post-op day 10, HB grade 3. Conservative management was given. Facial paresis improved to HB1. Prosthesis. So there are different types of prosthesis available in the market. We are most commonly we are using the Teflon piston, fluoroplastic piston. The disadvantage of this piston is you have to crimp manually. These two pistons, like titanium clip piston and Kurtz piston, they are auto crimp mechanism. So in this surgery, optimal piston length measured to incus plus 0.25 millimeter. If the piston is too long, then it causes vertigo. If it's too short, then it leaves residual airborne gap. Crimping must be circumferential, not oval. Footplates. Establish a safe control hole or traction point prior to down fracture to prevent floating footplate. Use low power, no touch laser or feather touch microdrill to minimize acoustic trauma. So what complications we can encounter in these surgeries? First is floating footplate. So we have to secure from promontory side. We can use right angle pick and we have to avoid the vestibular retrieval. Perilymphatic fistula. It can happen inadequate oval window seal. Symptoms fluctuating SNHL and vertigo. We can use the fascia or vein graft. Intraoperative risks, floating footplate, perilymph gusher and structural injury. Post-operatively, we have to look out for vertigo, granuloma and perilymph fistula. Floating footplate. As I have told, secure from promontory side, never chase fragments blindly into the vestibule. Gusher management, elevate head immediately, place fed graft into oval window plus piston to tamponade. And if we are suspecting fistula, then urgent exploration if fluctuating SNHL and vertigo was present, revise graft and prosthesis. These are my references. Thank you.
Thank you, doctor. One question you mentioned in probably the first case or the second case maybe, that you performed eticotomy, you said. Why was that?
For the better exposure, sir.
The stapes is in the posterior tympanum.
Yes, sir.
They are in the attic. You want to expose. What structure is there in the attic you want to expose?
The footplate is not visible, sir. That's why we have performed the eticotomy.
You are telling eticotomy.
Yes, sir.
If you use the term eticotomy, then you are breaching a different region of the middle ear.
Yes, sir.
Just for exposure.
Yes, sir.
And I am not sure whether that is necessary. But other judges can say.
Whether you mentioned it eticotomy or posterior superior overhang.
Yes, sir.
What do you want to mean?
Yeah, overhang, sir.
It's overhang.
What I am saying, you are a postgraduate student.
Yes, sir.
If you utter this eticotomy term in the examination,
Yes, sir.
you will be in a little difficult position.
Yes, sir.
So it is better to say extended overhang drilling, whatever you use, but eticotomy is a different operation,
Okay, sir.
and probably we would not require to open the attic.
Yes, sir.
Okay?
Yes, sir.
In the attic area you might have drilled, but eticotomy probably we do not
Yes.
subscribe to that. Next thing is the partial stapedectomy. What was that? We could not understand.
So the patient had undergone surgery before in 2013. The long process of incus was necrosed. So we have to we removed the old piston, and then we removed the anterior crus of the stapes footplate.
Okay.
Suprastructure.
And then?
Then we have placed the temporalis fascia graft, and then we have done malleolovestibulopexy we have put the piston over the handle of malleus to the.
Okay. Thank you. So it's a nice collection of cases. Thank you.
Thank you,
Any
sir.
questions?
The next presenter is Dr. Shubhashri Ghoshal. Her topic is anterior tucking versus circumferential tympanoplasty technique in subtotal perforations, a very common procedure that we regularly perform.
Good afternoon, all the esteemed surgeons. I am Dr. Shubhashri Ghoshal, first year PGT in the Department of ENT and Head Neck Surgery. And my topic is anterior tucking versus circumferential flap technique in subtotal perforations. The chronic otitis media, particularly the inactive mucosal variety, pose a significant health burden, especially in the developing countries like India, and data suggests epidemiologically the burden of chronic suppurative otitis media is 3.7 to 3.8% in our country. Subtotal perforations, they continue to pose a significant surgical challenge due to inadequate anterior remnant, increasing the risk of graft medialization, residual perforation, and surgical failure. So circumferential tucking tympanoplasty, it involves elevating the tympanomeatal flap 360 degree and placing the graft medially, tucking it under the annulus. And the anterior tucking, it specifically secures the graft beneath the anterior annulus to prevent medialization and displacement of the graft. Aims and objectives is to compare the anatomical success and the functional outcome of circumferential flap and anterior tucking tympanoplasty, specifically in subtotal perforations. So a prospective randomized control trial at Southeastern Railway Central Hospital for 3 months conducted. Group A has undergone circumferential flap tympanoplasty, Group B undergone anterior tucking tympanoplasty. Pre-operatively and post-operatively, they were evaluated using autoendoscopic examination and pure tone audiometry for assessment of graft uptake and hearing improvement. And the results are expected to provide insight into the most suitable surgical approach in subtotal perforations. These are the inclusion criteria, where the patient age is 18 to 65, diagnosed with inactive mucosal chronic otitis media, dry ear for at least a month, and conductive hearing loss as suggested by pure tone audiometry. An exclusion, patient with active discharge, small perforations, squamosal disease, and revision cases if there is eustachian tube dysfunction and uncontrolled diabetic and immunocompromised patients. This is a sample case from the anterior tucking tympanoplasty group, where a 21-year-old male presented with complaint of intermittent yellowish mucoid discharge from the left ear for 1.5 years and hearing loss for 6 months. And as you can see in the picture, the left tympanic membrane subtotal perforation was present on autoendoscopic examination. And on PTA, we see left mild conductive hearing loss of 30 decibel. And we diagnosed it as left chronic otitis media inactive mucosal variety with left mild conductive hearing loss, and plan for anterior tympanoplasty technique. So here an incision is being given in the posterior wall at 6 o'clock, followed by at 12 o'clock position. Graft is being elevated. An anterior incision is being given at 2 to 4 o'clock position for making the anterior tunnel for tucking of the graft. Tunnel is being created. Canaloplasty is being done in this case because the canal was narrow, so for better exposure for the tucking. And a graft is placed. The graft will be placed medial to the handle of malleus and it will be tucked along the anterior tunnel. Another case from the circumferential tympanoplasty group, where a 38-year-old female presented with recurrent mucopurulent discharge from the left ear for past 1 year associated with left ear conductive hearing loss. In the autoendoscopy, it revealed subtotal left tympanic membrane perforations, and the PTA suggested a conductive hearing loss of moderate degree, 45 decibel. So we diagnosed it as left chronic otitis media inactive mucosal disease with left moderate conductive hearing loss without any complications. This is the operative video for the circumferential tympanoplasty technique. Where again the posterior canal wall, the cut is being given from 6 to 12 first, and the flap will be elevated 360 degrees circumferentially. Elevation of the graft is being shown in the video, and further temporalis fascia graft will be placed medial to the annulus, and the tympanomeatal flap will be repositioned. Graft is tucked medial to the handle of malleus. So the review of literature. From the available literature, despite advancement in the otological procedure, the subtotal perforations have been a difficult scenario to manage, and it's a matter of debate which technique is best. Conventional underlay, although widely practiced, it has its limitations in subtotal perforations. As Khan, MM and Parabesa reported, higher incidence of graft medialization and residual perforation with conventional underlay, and modifications are required to improve the anatomical success and better positioning. So anterior tucking specifically addresses this inadequate anterior graft support. Singh et al. Showed that anterior tucking, it significantly improves the graft uptake by stabilizing the graft beneath the anterior annulus compared to the conventional underlay method. Verma S and Misra S also observed that the high graft uptake rate is there in the subtotal perforations. Indian studies have also demonstrated the real world outcomes following tympanoplasty. Also in circumferential tympanoplasty technique, the coverage of the graft and the stabilization is better. Both the techniques, they are widely practiced and have demonstrated graft uptake rates over 90% with significant post-op hearing improvement, typically showing the airborne gap closure of 10 to 20 decibel. After 3 months of post-operative period, our study showing 92% of graft uptake in the anterior tucking group and 94% in the circumferential group, and the airborne gap improved from 31.3 to 14.56 in case of anterior tucking and 30.1 to 13.88 in the circumferential group. So subtotal perforations, they are more prone to failure after the underlay, and both the techniques, circumferential and anterior tucking tympanoplasty, they have shown significant improvement in hearing following the surgery, as in our study it's 17.2. These are my references. Thank you.
Thank you, Doctor. Yeah, since this is the last presentation, we'll be quick. First question, how did you, what was the method of assignment to group? How did you group
Sir,
them?
it was randomized with help of SPSS software. The randomized sequence was created, and opaque envelope, they were randomly assigned at the time of surgery. The envelope was opened, and one A or B is written on that. So based on that, we chose the group which surgery to perform.
The second question is, I know it's a small number, but yes, could you get any statistical analysis of this?
Sir?
Is there any statistically significant
so the
improvement?
sample size is very less to make it statistically significant. So we're working on that. As of now, I have collected this much data, so I presented. But I'm working on that.
Both are equally effective, you mean to say?
In this small sample size, both shown equal improvement in hearing and almost comparable graft uptake.
And the last question from my side is, what is the disadvantage of elevating its 360-degree flap?
Once our operating time is more, it's a meticulous technique, so precision is required for that. And there can be chances of lateralization And also medialization, if it is not put properly, if the tympanomeatal flap is not repositioned properly, then there can be complications, sir.
Thank you.
Hello. In case of anterior tracking, whether you reinforced with gel foam in the middle ear?
So depend on the cases. If there is no requirement, we don't do it. But if there is any cavity formation or if there is any empty space, then we put gel foam and after that we tuck.
Okay.
Thank you. Thank you, everyone.
So it's the time for delivering the certificates to each of the presenter. First I call upon Dr. Shubhashri Mandal. I would like to request A.M. Shah sir. Sir, please come. Along with Haradhan Bora sir and Dr. Urunabhushan Gupta sir to come in front and deliver the and hand over the certificates to the presenter. The next is Dr. Boshundara. I guess Boshundara is not present, so I would request Shubhashri again to collect the certificate of the Boshundara. Dr. Raghav Gupta. After Raghav, Dr. Ambi Katyani. Then to Dr. Akash Jain. So we have 9 participants. So each of our senior colleagues, sirs, have the opportunity to deliver 3 certificates. I would again like to request Dr. Probir Basu sir to please come in front to deliver the certificates. So we are exempting the first benches. The next is Dr. Debarpita Samanto. Okay. So the audience demands Dr. Doipan Mukherjee to please come in front to deliver the certificates. Dr. Probir Basu sir already handed over. Dr. Dipankar Mukherjee sir, audience also wants you to deliver the certificate to the participants. Dr. Nilanjan Chando. Gurtu sir, you are also please requested to come. And Dr. Atul Anand. Yes. And the last one is Dr. Shubhashri Ghoshal. So here I would like to conclude this session. Thank you all the judges, the audience, the participants, and hope we will be enriched in future by more of this kind of discussions. Over to Ajoyda, the secretary.
Good afternoon. So we will announce our next clinical meeting. It will be on 27th June at Ramakrishna Mission Seva Pratishthan. 27th June. Next clinical meeting. Thank you.